My wife is a primary care physician, and I won't tell you her name because it is different than mine out of disclosure, because she confessed to me that on occasion she doesn't know what's going on with her patients. She checks the vitamin D level, the levels are low. She has no idea by replacement if it's actually going to help them, but it actually helps the patient, because then the patient says, I know my level is low, I can correct that, and all that ails me potentially can benefit.
Right, and there's no question that people come back and say they feel better, and the doctor feels better because you have a measurable outcome. That it's a surrogate, becomes the outcome because it goes up, and we know that D goes up with supplementation.
So in effect, you're using it as a placebo?
Well, I don't think anybody would say that, but
I didn't say that.
Right. So I'll just give a quick anecdote. Unfortunately, you know, being on the IOM committee, I gave tons of talks all over the world on vitamin D, and among physicians, when I asked them how many people take vitamin D, almost everybody, the question that Michael asked was that, yes, I take vitamin D, and how much, and, you know, 90% or 2,000 or 5,000 or 10,000. And when I say, well, there isn't the evidence, their response is, but there will be ultimately, so what's the harm?
Elizabeth spent more than a week at Children's Hospital and Medical Center, where blood work spelled out the problem.
She had very high vitamin D levels.
Toxic levels of vitamin D and calcium, which made everyone question what the baby was eating.
Joe was the colicky one. So he did better on just breast milk. And I didn't have enough for everybody to be on just breast milk.
But you wanted the best for your baby.
I did. Since I couldn't give them both 100% breast milk, which is what I would have preferred, I wanted to do the next best thing. The base of the formula was the goat's milk and coconut milk.
Becky was mixing up an organic, homemade formula for her daughter with a little something extra.
I was adding too much vitamin D. I wasn't following the recipe as it said. I was adding more because I thought, well, more must be good.
Instead of a drop, she added a dropper full of vitamin D to each batch.
So about 8,000 times more than she was supposed to have.
Dr. Cabrera says too much calcium from vitamin D can cause kidney stones, kidney failure, and heart trouble.
It can deposit in blood vessels as well. It can cause arrhythmia or irregular heart rhythms.
I didn't have any idea the impact it could have.
IV fluids and adjusted feedings put Elizabeth back on track and back on the growth charts. And this mother of twins, she's thankful for no lasting consequences.
I think that it's just important to realize the impact that vitamins can have, negative and positive, and to not think that it's okay, oh, it's just a vitamin, it's no big deal.
The baby's calcium levels are normal now. Her vitamin D is still very high. Vitamins A, D, and E remain in body fat, and so they accumulate, and the body can't get rid of them quickly.
If we had the perfect gold standard for 25D, so the measurement was absolutely spot on, there was no variability. In the decision-making tree, are you comfortable that you could move forward towards one of those two thresholds of either diagnosis or treatment based on the evidence that you've heard, particularly about outcomes? So remove all that variability around the assay. How likely is it for you to feel comfortable about talking with your patient about the result of the 25D in response to what they're querying you about, particularly in terms of chronic diseases?
No, definitely not. Definitely not comfortable there. And I actually have a question for the rest of you along this line based on, but you know, it's obviously the first step is what Andy was talking about and what Ian and John, you know, and others have expertise on it, which is the technical aspects of getting this right and measuring, knowing what we're measuring and what it's telling us and things like that. But the next question is that where I haven't heard any consensus at all over the last day and a half is, you know, what does this mean? You know, you get a number, and, you know, it's like the old Buffalo Springfield, something's happening here, what it is ain't exactly clear. You know, what does this mean for the patient? What does this number mean? And one of the things that struck me yesterday was, what does a cross-sectional measure mean in a lifetime of vitamin D? And what's the correlation between a serum level and physiologic health and, you know, pathophysiologic status? And I don't have a good sense of that. That this is ready in the sense, if you can get the assay down, which is crucial, this is ready for a lot of, you know, for some really important clinical research questions that would allow this to be ready for prime time.
All of the genetic evidence that's been coming out over the last half decade to decade is suggesting that the selective pressure on genes favoring light skin occurred independently in Europeans and East Asians about 10 to 20,000 years ago. If selective pressure was so strong from moving to less equatorial latitudes, then why wasn't that selective pressure there as soon as that migration started happening? What could explain this massive time gap between the migration and that selective pressure? The second problem is that when you aggregate all of the data across the globe, what you see is that in Caucasians, represented by this dotted line, the further you get away from the equator, the lower the 25-OHD that you have. But that trend is not true for non-Caucasians, where as you move away from the equator, the average 25-OHD remains stable. Second of all, at any point here, the Caucasians have higher 25-OHD than the non-Caucasians, just comparing the dotted line on the top to the solid line on the bottom. Moreover, if average 25-OHD of the Caucasians is higher at the temperate latitude, even than the average 25-OHD of non-Caucasians when you get closer to the equator. Now, granted, as you can see from these individual dots, there's lots of spread across these averages, but you can still tease out the average from all those individual data points. And what you see there is far more consistent with the idea that Caucasians in general just have higher 25-OHD than non-Caucasians, and is not at all consistent with the idea that as non-Caucasians moved out of the equator, they needed to have lighter skin so that they could get 25-OHD, so they could retain the 25-OHD they had at the equator. This data doesn't look like it fits with that hypothesis at all. Now, the third problem is that same study of 105 black and white adolescent American girls that I showed you at the beginning, if you look at the 1/3 lower 25-OHD that I showed you before, the threshold of adequacy for 25-OHD is actually set at what is the amount of 25-OHD that you need to maximally suppress parathyroid hormone, or PTH. And that's because the more vitamin D and calcium you have, the lower your PTH. And you want PTH to be low because PTH is what recognizes a deficient vitamin D and calcium economy and causes you to leach more calcium out of your bones. So the threshold for adequate 25-OHD is actually set on suppressing PTH so that you don't need to release as much calcium from your bones. Now, if you look on the right, what you see is that the black girls in that study had just under 10% more total body bone mineral content than the white girls had. Given the fact that the whole idea behind the reference range is to suppress PTH to support bone mineral content, the fact that blacks have higher bone mineral content at least makes you ask the question of whether there isn't more to the story here than what we're seeing. But now that we have an understanding of the genetic differences, we have to realize that it's not about the group, it's about the individual who has those genes. And then B, those genes don't have anything to do with skin color, which is the biological basis by which we're defining these groups. And whether you're defining them by skin color or by ancestry associated with that skin color, it's still a fact that these divisions between racial groups originated because of social divisions, and they don't actually correlate to or define the biological differences that we're interested in. If you look just within white Americans, there's no effect of this genetic polymorphism. How can it have such a dramatic effect on African Americans and such lack of effect on white Americans? Well, it must be, assuming that it's a cause and effect relationship, which it probably is because we don't choose our genes, so they're kind of randomized in that sense. if we make that assumption, then it must be something about the context in which that genetic polymorphism is operating in. That could be the context of other genes, or it could be a context of a diet and lifestyle factor. I want to put forth a hypothetical possibility that can explain this, and that is maybe this genetic polymorphism, maybe the ancestral allele allows us to gain more calcitriol without a need for PTH when calcium intakes are consistently marginal. The black girls have higher calcitriol, and although there's no statistical difference in PTH, that higher calcitriol, if you take the ratio of calcitriol to PTH, it's higher in the blacks than in the whites, suggesting a relatively calcitriol dominant state instead of a relatively PTH dominant state. In other words, they're getting more biological vitamin D activity with less cost of PTH elevation. And so that allows more calcium to come in from food for higher fractional absorption of calcium from food and less of a need to leach it out of the bones. That could explain higher bone mineral content in these girls. Let's shift gears here to another group, the Inuit. And this is a study where they compared Greenland Inuit to Danes. The Inuit were on either a Western diet or a traditional diet. The Danes were eating a Western diet. And so here you are looking at the Inuits and Aleuts, we used to call the Eskimos. So these are the natives inhabiting the Arctic Circle. And what we see here is that if you just look at the purple and green bars, you're comparing for the Western diet, and you're just looking at the difference between Inuit and Danes. And what you see is their 25-OHD is low compared to Danes, but their calcitriol is higher and their PTH is lower. What happens if you put the Inuit on a traditional diet? Well, look at the red bars. 25-OHD goes up to where it's equal to the Danes. For calcitriol, it goes even higher, and for PTH, it goes even lower. Again, we see another example where when we're looking at non-European ancestry, we're seeming to see greater calcitriol dominance, less PTH dominance, greater ability to make calcitriol without the cost of PTH. And you could say maybe 25-OHD is low because you're making calcitriol from it. And if that's the case, it's not necessarily a bad thing if it's leading to lower PTH in the big picture when you combine all those things together. This is a study of Hawaiian students and skateboarders who had average sun exposure of 22 hours a week without sunscreen. If you adjust that for their clothing, it's 11 hours a week of total body unprotected sun exposure. And you see the whites have 37 nanograms per milliliter. The Asians have 25 nanograms per milliliter. If they're multiracial, they're in between. I don't have PTH and calcitriol data in this case, but again, it seems to be the case that when you're looking at people with non-white ancestry, once again, you see 1/3 lower 25-OHD. That's very consistent across these very different groups. And so what I would say is that for practical purposes, to some degree, we can say maybe it's less likely that if we observe someone with non-white ancestry as having, say, a 25-OHD of 25 nanograms per milliliter, maybe it's less likely that they need to supplement with vitamin D than if we observe the same thing in someone with white Western European ancestry. But ultimately, those racial categories are not getting at the root of the issue, which is what are the genetics in the vitamin D metabolism genes. And I don't think we're there yet to practically apply those genetics in a way that we can know what all of them are doing in combination and how they're dictating someone's vitamin D requirement.